Welcome to today's live. Yeah, we are just going to be studying together in preparation for exams. So please join me, keep me company. Okay? Yeah, it's a lot of work to do. So a moment as I set up. We are setting up. I was looking at bands. So what is the criteria of transfer or to refer a patient with bands? So the total band surface area should be above 10% for children and 15% in adults. And the band should involve the face, the hands, feet, genitalia, perineums, and major joints. And the band should be 3rd degree and above. Electrical bands, chemical bands, inhalational bands, and a patient with bands who have pre-existing conditions like diabetes mellitus or other chronic diseases. We have any patient with bands with concomitant trauma, that is maybe fractures, and we also have burn injury in patients that will require special social, emotional, or rehabilitative intervention, and circumferential burns, that is maybe to the limbs or the chest. So those are indications for referral. So pathophysiology of burns, it's just a quick. We are studying for exams, so we are just quick. I have problems maneuvering between these two. So we enter intestinal obstruction. Turn this so that I'm also writing down. What are the features of intestinal obstruction? One will have abdominal distension or abdominal swelling, can have vomiting, mostly in small bowel obstruction, distension mostly in large, of course abdominal pain, that is colicky in nature, and obstipation, that is failure to pass stool or flatus. People say to pollute, obstipation. So we have abdominal distension, vomiting in small bowel, abdominal pain, and failure to pass stool. So we are using some questions. That's why I need to go back. So during diagnosis in X-ray, what are the views? during an X-ray. So one will have a supine abdominal X-ray, erect abdominal X-ray, and erect chest. So what are the findings in small bowel? We have central dilated loops, valvuli conniventes, they'll be crossing the entire lumen, and large bowel. We have peripheral dilation. We also have the house truss that do not cross entire lumen, and air fluid levels. It's just a quick summary. So another question. So we've said for the X-ray views, supine, erect, abdomen and chest. And the next question is differences between small and large bowel obstruction as seen in X-ray. So for small bowel, location it's central abdomen. Large bowel, it's peripheral or along the colon. Diameter to be dilated more than 3 centimeters. For large bowel, dilated more than 6 centimeters, and the cecum 9 centimeter. So mucosal folds, small bowel, valvuli conniventes, in large bowel house truss, folds in small intestine. They cross the entire width of the bowel, but in large intestine they do not cross the entire width of the bowel. The shape in small intestine, multiple centrally located dilated loops. In large peripheral, often called more colonic or frame-like. Yeah. The fluid levels in small, they're numerous at different heights. In large, usually fewer, larger levels. Rectal gas may be absent in complete obstruction of the small bowel, and large bowel, they are often absent in complete obstruction. So common sign for X-ray in small intestine, we have the step ladder pattern or the stack coin patterns. In large, we have the coffee bean sign in sigmoid volvulus. So that is it about that question. So another question. This is an orthopedic question. kindly subscribe as we continue with the session. We'll just be mixing up the cases, both surgical and orthopedic. So for is it Colles or Coles fracture? It's a transverse fracture of the distal radius, usually about 2 to 3 centimeter proximal to the wrist joint. Okay, with dorsal displacement and angulation of distal fragment. I have to write these things down, that's why I'm taking a bit of time. So, mechanism of injury. So, there is fall on an outstretched hand with the wrist extended. So, you fall. Here there is Jen Mwaka, hatulali tunakesha. Yeah, we are transmitting, guys. So you'll be with me in this live. Welcome, Jen. Study with me. Yeah. So mechanism of injuries of Colles fracture. Mechanism of injury, fall of an outstretched wrist that is extended. Yeah. So the impact is transmitted through the extended wrist, causing the distal radius fracture, and we've said it's a transverse fracture. So the distal fragments do not, so the distal radius makes the what is it called, the distal fragments to move dorsally and radially. So how will be the clinical appearance? Yeah. So one, we have dinner fork deformity of the clinical dinner fork deformity of the wrist. We'll have pain, of course, and swelling. We'll have tenderness on the distal radius and a possible median nerve compression. Okay, that's just a brief about the Colles fracture, distal radius. Okay, outstretch, extended wrist. What's the next question? Okay. Don't worry, I have to shift from one side to the other. So we are still in orthopedic case. Carpal tunnel syndrome. For me, I have to write. Okay. I retain more while writing. So, which nerve is compressed? Median nerve. Okay. As it passes through the carpal tunnel of the wrist. Yeah. So, what are the causes or risk factor? Pregnancy, diabetes mellitus, rheumatoid arthritis, hypothyroidism, obesity, wrist traumas or fractures, especially the Colles fracture that we've seen, then repetitive wrist movements and space occupying lesions. So for the clinical presentation, we've said it's compression of the median nerve at the carpal tunnel. So one clinical manifestation will have sensory, so numbness and tingling, that is paresthesia of the thumb, index finger, middle finger, and radial half, that is the dermatome that it supply, of ring finger. Yeah, just the radial. All right. So the symptoms worsen at night and they may wake the patient. The patients may shake or rub the hand for relief. Pain may radiate from the wrist to the forearm. So that was sensory. For the motor components, we have weak grip because you know this thumb has a very important function. So weak grip and most of the fine movements will be impaired, and weakness of thumb position and abduction. Yeah. So in advanced, we have muscle wasting of the thenar, muscle wasting, and the flattening of the thenar eminence. So for the clinical test, phalanx test, which flexion for about 60 seconds produces symptoms. Phalanx, so T-nail sign, tapping over the median nerve at the wrist produces paresthesia in its distribution, and carpal compression test, direct pressure over the carpal tunnel produces symptoms. So investigation, nerve conduction studies. Yeah, so this is median nerve. So blood tests may be done. So management, one we start with the conservative management. A moment, I have to join someone. I have to reply to the comments first. So conservative management. So for mild wrist splint, avoid activities that aggravate the symptoms. Treat underlying conditions. Example: the diabetes, hypothyroidism, NSAIDs and analgesics, corticosteroid injection. Yeah, temporary relief. So we have surgical. It's indicated for severe ones, and then wasting and all that. So operation involves the dividing of flexor retinaculum transverse carpal ligaments to decompress. Yeah, because we have compression, so treatment will just decompress. So another quick one. Yeah, still in bones. We want to look at rickets. So rickets, infantile rickets, disorder of the growing skeleton caused by defective mineralization of the growth plate and newly formed osteoid, mostly commonly due to vitamin D. I know you already know that. Yeah, what are the causes of rickets? So pathophysiology, there's one, the vitamin D deficiency leads to decreased absorption of calcium and phosphate because it's the one responsible for that. So hypocalcemia, yeah, because there is a decreased absorption of calcium. Then a parathyroid hormone will increase, that will lead to increased renal calcium absorption, increased phosphate excretion, increased bone resorption to maintain serum calcium, and which will lead to hypophosphatemia and defective mineralization, accumulation of unmineralized osteoid and failure of normal mineralization at the growth plates. So that will lead to rickets. So one, there's the vitamin D deficiency. So that leads to reduced intestinal absorption of calcium. If there is in calcium and phosphate, if there is the reduced absorption, there is hypocalcemia increasing. Okay, it will increase parathyroid hormone, which will increase renal calcium reabsorption, increased phosphate excretion, increased bone resorption to maintain the calcium, so the bones will be resorbed to increase the calcium levels. So will lead to hypophosphatemia and defective mineralization, that whole bone process thing, then leading to accumulation of unmineralized osteoid and failure of normal mineralization at the growth plate. So it will lead to rickets. So at the growth plate, there'll be widening and disorganized because the cartilage proliferation continue, but there's no normal calcification and replacement of bone. So what are the clinical features? General, we have poor growth retardation, irritability, muscle weakness, hypotonia, delayed motor milestones, bone pain or tenderness. To the skull, we have craniotapes, which are soft bone skulls, delayed closure of the fontanelles, frontal parietal bossing, delayed dentition, like anything literally dealing with bones and calcium and phosphate. So chest, rachitic rosary, so is the enlargement of the costochondral junction, Harrison sulcus, horizontal groove along the lower chest, chest deformities, of course, because there are bones, the ribs there. So the limbs, there'll be widening of the wrist and ankles, bowing or bowing of the legs, genovarum, board legs, genovarum, genovalgum, fractures, yeah, they are common. So they span kyphosis or scoliosis, pelvic deformities in severe case, muscle, there be hypotonia, proximal muscle weakness, delayed sitting or walking. So for the radiological findings, so radiological findings. Let me see. I have water with me. I'm talking a lot and I need to hydrate. Okay. Subscribe as I drink water. So X-ray, there is widening of the growth plate, metaphyseal capping, metaphyseal fraying, metaphyseal splaying or flaring, loss of the sharp zone of the provincial calcification, generalized osteopenia, cortical thinning, bowing deformities of long bones, delayed skeletal maturation. So there's widening of the growth plate. Okay. And metaphyseal capping, fraying, flaring, and all that. For the lab findings, 25 hydroxyvitamin D will be reduced. Phosphate will also be reduced. Calcium may be low or normal. Increased ALP, alkaline phosphate. Increased parathyroid. Low or normal urinary calcium. That's depending on the stage. Okay. We go back to surgical abdomen. So acute pancreatitis. Let me check the question. Causes of acute pancreatitis. The common one, gallstones and alcohol. Yeah. So other important causes, we have hypercalcemia, abdominal trauma, hypertriglyceridemia, triglycerides. Yeah, increased triglycerides in the blood. So drugs, infection like mumps, Coxsackie virus, autoimmune pancreatitis, pancreatic or biliary obstruction or tumors, congenital duct abnormalities, ischemia, hereditary pancreatitis, and idiopathic. So the major ones, they are the stones and alcohol. So what are the clinical presentation for acute? Classical presentation, this is acute abdomen. So there'll be severe epigastric pain. This is the hallmark, which is sudden, severe and persistent, radiating to the back, maybe worse after eating. So the patient, when they lean forward, it relieves the pain. So other symptoms, we have nausea, vomiting, abdominal tenderness, especially the epigastric area. We have abdominal distension, fever, tachycardia, dehydration, reduced bowel sounds, and severe acute, we may have hypotension or shock, tachypnea, hypoxia, confusion, oliguria, respiratory distress. So there are two characteristic signs, the Cullen signs, that is the periumbilical bridge discoloration, the gray Turner signs, that is the flank, the sideways, the flank ecchymosis. So Cullen signs and the gray Turner sign. So they suggest severe hemorrhagic pancreatitis and retroperitoneal bleeding. So investigations, one, serum lipase, which is preferred and it's more specific for pancreatic. So it rises within hours and remains elevated for longer, so it can be used. So we also have serum amylase. It rises within 3 to 6 hours. Okay. So for the diagnosis of acute, when the pancreatic enzyme are elevated more than 3 times of the upper limit, normal. So the blood test, full blood count, leukocytosis, hemoconcentration, we have usage to assess the renal function, dehydration, electrolytes, calcium and phosphate. Glucose may be elevated, the liver function test, especially if we are suspecting gallstones, CRP, severity, yeah, that is an inflammatory marker. We have arterial blood gas to assess hypoxia and metabolic acidosis in severe disease, triglycerides, if we suspect hypertriglyceridemia. Yeah, imaging, so ultrasound, of course, contrast enhanced CT, MRCP, complications. So we have the early pancreatic necrosis, acute peripancreatic fluid, acute necrotic collection, pancreatic peripancreatic inflammation, just inflammation and necrosis, okay? So later we have pancreatic pseudocyst, world of pancreatic necrosis, pancreatic abscess, yeah, abscesses is a long term or it's a later complication, okay? So pancreatic fistulas, portal vein or splenic portal vein thrombosis, biliary gastric outlet obstruction. So systemic complication, as you said, shock, acute kidney injury, acute respiratory distress, respiratory failure, DIC, metabolic acidosis, hypercalcemia, hypertriglycinemia, sepsis, particularly with the multiple organ failure. For the hypertriglycerides, you know the pancreas, the beta cells of the pancreas is responsible for the insulin production. So if it is damaged or it's inflamed, you know there's that impairment of the insulin. So we'll have hyperglycemia. That will be increased glucose levels. So we have a mnemonic of acute pancreas get smashed. So G, we have gallstones. E, we have ethanol or alcohol. T, we have trauma. S, we have steroids. M, we have mumps. A, we have autoimmune pancreatitis. Autoimmune. S, we have the scorpion venom. Scorpion. This is quite rare. Then H, we have hyperlipidemia. Hypercalcemia, and high thyroid. ERCP for the E, and D, we have drugs such as thiazides and valproate or valporic acid. Valproate. Yeah, get smashed. G, gallstones. E, ethanol or alcohol. T, trauma. S, steroids. M, mumps. S, we have A, we have autoimmune. S, we have scorpion venom. H, we have hyperlipidemia. E, we have ERCP. D, we have drugs such as thiazines and sodium valproate. So the other question, we go back to ortho bones, phases of bone healing. I'll just read from this book. It's a bit wordy. Let me just get a summary. I'll just be writing them down. So when the fracture occurs, we have hematoma. So when there's fracture, we have the disruption of the bone and blood vessels. Hematoma, so the blood collects around the fracture. Then inflammatory, of course. Inflammatory cells, they move around the damaged tissue and release mediators. Then granulation, tissue formation. So this is new blood vessels and fibroblasts develop. Fibroblasts. We have soft callus formation. Fibrocartilage, bridges of the fracture gap. Then after soft, we go to hard callus formation. Then bridging of fracture fragments. Then woven bone maturation. Then remodeling. Then restoration of normal bone architecture. So yes, healing occurs in bone fractures. So after the fracture, hematoma formation, inflammatory mediators, then the soft colors formation, and hard colors formation, consolidation, remodeling. Okay, this is a bit summarized. Remodeling, then restoration of the normal bone. What's the next one? Factors that interfere with healing. And this is here. So factors that influence healing, when we can have the patient's factor, that is the age, gender, smoking, radiotherapy, comorbidities, status of the bone, alcohol or drug use. We also have environmental factors, that is diet, malnutrition, of course, will delay. Biochemical factors, we have drugs mediate inflammation, blood coagulation. Mechanical, we have instability of the fracture site. Yeah, and can we have some more? Immunocompromised state. So what are the next question concerning acute appendicitis? Okay, I will write this one. What are the 6 signs? You will type them below. Pointing signs, Rovsing signs, McBurney's. We are not sleeping today. Well, it's 11:19. Don't worry. Yeah, so McBurney's point, that is the junction of the, is it lateral third and medial 2/3 from the axis to the umbilicus, so you draw a line there. Rovsing sign, palpation to the, mostly acute appendicitis occurs at the right, so palpation of the left induces pain to the right. Then psoas sign, the psoas and obturate, I can't demonstrate them here. So we have psoas sign, extension of the right hip, so that is suggesting retrocecal appendix. So obturator sign, internal rotation of the flex right hip, pelvic appendix. So there's carding, there's rebound tenderness. Yeah, that is when you palpate, then upon releasing, there is pain, then cough or percussion tenderness. So those are the signs. You also have pointing sign, just points the McBurney's point. Just the other question. Still about for acute appendicitis. We do score a moment. Yeah. Are you studying with me or you're just looking at me? Or I should just keep quiet. A moment, I check on something. I think I'll stop streaming. Yeah. I continue with a lot of work here. So yeah, thank you for joining me. At least you learned something, one or two. Quick review. Okay. The work is just a lot. Yeah, I think that will be it for now. I'm just seeing a lot of questions here that I need to handle. Yeah, I want to quickly go through everything here. Then I'll see you tomorrow. Bye bye. Let me come and cut the video.